Welcome to Voices in Value-Based Care. I'm Beth Hauk. Thanks for tuning in. The movement to value-based care is revolutionizing how healthcare providers get reimbursed for delivery of care. In this program, we're going to explore stories from the field about how real organizations are dealing with this change. You can follow the show on Twitter at #VoicesInVBC and follow me on Twitter at BAHauk. On the program today, I talked to Mark Kirschbaum, VP of Population Health at Morey Regional Hospital. Mark, welcome to the show.
Thank you very much. Glad to be here.
Well, I'm excited to talk to you today. I'm really looking forward to hearing a bit about your journey to adopt and optimize your population health program. On this show, we talk quite a bit about the tools and processes and changes that organizations need to make in order to get themselves ready or continue to comply with value-based care. And Pop Health is, of course, a very, very important part of that journey. So really excited to hear more about what you've learned and a little bit about your story at Morey. So with that, why don't you go ahead and tell everybody a little bit about yourself, your background, as well as the organization. Very good.
Morey Regional is a community hospital, county-owned in southern Middle Tennessee. We have a 250-bed large hospital in Columbia. We have a critical access hospital 30 minutes to our east, and a rural hospital an hour to our south. Morey has been working on preparing itself for accountable care for some time now. I joined Morey 2 years ago as VP for Population Health. My background was largely in quality, as the Chief Quality Officer for two large academic health centers in Wisconsin and Texas before moving to Tennessee. Morey was an enticing place for me to come because senior leadership was committed, aware that they needed to position themselves for the future strategically, and willing to make some investments. So we are headed down that path, and it's a very creative time, but we're learning a lot as we move along.
Probably a pretty interesting transition for you to go from two academic medical centers to a more rurally oriented health system. So fun new challenge. I talk to people all the time about all the data, information, tools, systems that need to be in place in order to really comply with new programs. What precipitated the need for a new product or tool for you guys? What was the problem you were trying to solve?
Sure. In 2016, Morey had begun to participate as a part of the CMS mandatory comprehensive joint replacement program as a part of the Nashville metropolitan service area. At that point, we relied at Morey heavily, and I'm saying we, although that predated my arrival, we relied heavily on an outside firm that did some analytics on our behalf. So our claims data for the joint replacement patients we cared for in partnership with orthopedists here in Columbia, Tennessee, we relied on an outside firm to do that analytics and produce it for us on a quarterly basis. We had gotten advice about making some strategic investments to position Morey for population health. One of the top three initial elections by Morey leadership was the establishment of the database. And that was our decision to move forward with Lightbeam as a partner in this journey. It was partly at the recommendation of an outside consultant who had worked with Morey on identifying what were the building blocks we needed to succeed in this value-based arena. And it was basically a transition for us to move away from a dependency on outside folks doing the analytics for us to how could we manage our own information internally. So Lightbeam was recommended among a couple of competitors. We narrowed Morey narrowed the selection down to Lightbeam, and by the time I got here in April of 2017, it was up and functional. They brought it up in about 4 months. One of the criteria that Morey was looking for was a niche player, somebody who knew this population space very well, and Lightbeam was that. They were able to bring it up fairly quickly. And one of the problem we were really trying to manage was how how could we manage these Medicare Shared Savings Program claims data files. So after our work with the CJR program, we also in January of 17 entered as a participant in CMS's Track 1 MSSP program, and so we were going to start receiving claims data for our attributed primary care patients in traditional Medicare. Lightbeam had that experience and was able to help us overcome the challenge of how do we ingest that data and how do we start to make sense of it. Lightbeam brought as a niche player, some intelligence to the table about accountable care and how other ACOs across the country were managing some of the immediate problems. So we were really trying to just become masters of our own data so that we could better succeed as an accountable care organization, acknowledging we were very much a startup.
Your experience, kind of broadly at the other academic medical centers, then of course, what brought you to this challenge? What throughout all of your career really have you learned? What's the hardest part about adopting a new analytics tool like this? Like are some of your biggest challenges that you end up facing?
I think the Lightbeam work here is, that's a great question. It's like other projects that I've had some experience with. In working in this analytics space, a few things immediately pop up. This is just plain hard work. There is a good deal of tedious, meticulous work that has to happen on the front end to produce value on the back end. So not only were we, as an example, not only were we ingesting these claims files coming back to us from CMS, but we were also bringing over data from two disparate, an inpatient system and a clinic-based system. Murray's approach was that we did not have a single integrated platform. So when I say painstaking, meticulous work, it's really the ETL process of bringing data out of our familiar electronic medical records and moving it into the Lightbeam store and marrying it up with the CCLF files from CMS. And we discovered a number of things in that process. We had, of course, as a challenge, two disparate EMRs that we were trying to work from, which our own internal users, providers, of course, had their own challenges with working with multiple systems and some fragmentation that occurs. But painstaking work, because what field that might be named, having an alphanumeric X number of digit spaces to it, if I want to join or marry it up with data from the other record that has a different set of qualifiers, all the work that goes into doing that. We are a small organization, so our IT group also brought in an outside contractor to do that initial ETL work to feed Lightbeam. That contractor, of course, was new to us, wasn't familiar with Murray, and Lightbeam was a new challenge for them as well. So there were some mistakes made along the way by that contractor and some learning that just simply had to happen. So probably the biggest challenge I think we had on the front end was investing the time and the detailed focus to get the data in properly. And we acknowledged that the data were not entirely clean and there was work ahead of us. And I think one of the other challenges, I'm a nurse by trade. I come from a clinical background. Of course, we're all excited and interested in the utility, the benefit, the value of that data and how it might direct our work. And so we want to get to the business of using it, and yet that front work has to happen well to make sure that there is value on the back. We learned early in our process that there were some challenges with our lab data, for instance, and clarity of the data that was coming across. That influenced negatively the validity or the reliability of the few of the accountable care quality measures that depended on the accuracy of that lab data. So we had right out of the chute, some initial cleanup to do. And my experience to your original question is that clinicians are pretty quick to find fault, pretty quick to find flaws in the data. And once they've done that, they can pretty quickly also sort of turn off and say the data are wrong, the data are not useful, and just be unwilling to use it. So in my experience, we've got to put a lot of effort in making sure that we avoid that problem and that we get the data as clean as we can possibly get it. I think most data hounds would be comfortable in saying there's no such thing as a perfectly clean data set, and there will always be issues that we need to manage. It's a little harder when you're speaking to a room of clinicians and primary care providers about their performance on quality measures when they're beginning to draw conclusions or take pot shots at the validity of the data in front of them. So I think our single biggest challenge is getting that data right, because we want to make good decisions. We want the data to be accurate. We want our end users to be very comfortable with that. We kept the data sort of close to vest with a small group of internal folks for quite a while, and only slowly started inoculating some of the medical leaders, and for instance, with some of the data as we got them to work with us on the journey. So Lightbeam, as an example, offers a really tremendous risk adjustment, risk assessment of our patients. And we simply created some very crude output for our clinicians to be able to look at patients who were impaneled to them, at their risk scores, and help do some sort of face validity checking to make sure that the risk score attached, even though it was a Johns Hopkins Ambulatory Care Group risk score with some good work behind it, that it had face validity for our clinicians. You know, is this patient sicker than the other?
Yeah, you're actually answering a question that I had in my head when you were describing all of that tedious data work, because I can only imagine that was, an enormous lift. I also have heard from so many different sources and so many different people the whole concept of the data has to be near perfect to be put in front of clinicians who are being potentially judged on their performance. So with all of that as a backdrop, I did want to understand, like, what did you do for some of your quick wins? Like, what did you put in front of people so that you could say all of this is worth it, and I need you to start to believe it and kind of operate with this data as if it were perfect? What did you do?
I'll give you the most salient example that was not with our physician leadership, but with the operations leadership, the senior leadership for Murray. One of the problems we had to solve was how did we stand up a group of ambulatory care coordinators or ambulatory care managers. We're calling them care coordinators here at Murray. But these are individuals who help, once we've identified patients who are at high risk with chronic illness, whether it's COPD, heart failure, diabetes, or that they're simply high utilizers of our emergency department. In order to get support from administrative leaders about needing to invest in those individuals, we were able to use the Lightbeam data and those risk scores to identify how many patients were impaneled at each practice setting, at each location for each provider. How many were there? We used some industry estimates that came from our consultants about for the very high risk patients at the top of the pyramid, what's the ratio of patient to care coordinator, care manager that typically the care coordinator can manage? Well, given that we were able to quantify exactly how many patients at high risk who hit a certain cutoff we had in each panel, it gave more credence or veracity to our predictions about how many individuals we would need to manage that. And so without that risk data that was provided in the Lightbeam infrastructure, we would have been hard pressed, and we would have been sort of guessing likely numbers of individuals and likely numbers of patients at high risk that we might have. But because we had good, and while it's billing data, I've learned to sap every ounce of benefit out of billing data that we can get, good coded data that would at least tell us how many of those patients with a certain level of risk we had, and be able to design our our group around them. Now, we are a full year into having those care coordinators, and we're coming back to revisit those assumptions, and now we have some data to speak from. But it was invaluable early up, and even though I mentioned that there were still some validity issues we had to work on, mostly on the quality measure side, it gave a credible base for recommendations about plain hires, how many people we needed to bring on board and invest in to help complete one more set of our building blocks.
Is it your job and your resources job to interpret data in such a way that make it easier for these non-data people to know what to do next? Or do you also have to teach these care coordinators, other users of the information, how to interpret data in a new way?
Boy, that's a great question. I think we're all learning together. So I think we bring, I personally will bring a little bit of data facility and interpretive, so I think you hit the nail on the head, interpretive capability to the table. I'm being both a clinician and a card-carrying geek, or at least a geek wannabe. I think I can speak in both worlds and translate between. I'm also humble enough to say that our care coordinators have a tremendous understanding of the day-to-day clinical challenges in front of them. So they're able to, they're quick learners. We're able to identify what are some opportunities, where do these data help them, and where are its limits. So I think we're all learning this piece together. But yeah, I think in a circumstance like this where we're trying to create value from that data set, it is a primary job to translate that and get meaning to the table that improves our decisions and improves the process for us. But I'd be remiss if I didn't confess that this is new work for all of us. I didn't come to Murray with 8 years of accountable care experience in another ACO, and so we're all learning a bit together in this one.
So along those lines, I think it's an overused term, but it works so well I have to use it again, which is it's probably boiling the ocean. Like, there's so much data that you have, so much infrastructure that you've put in place, kind of good foundation. So now, how do you figure out which things to be working on? Which ones do you kind of point your arrow towards, and then how frequently do you add on new initiatives so that it doesn't feel too overwhelming?
Well, I think everybody that works with me would tell you that I fail at the latter question all the time. I have big eyes, and I get excited, and we tend to want to do a lot of things. To your key question about how are we using this to prioritize and where are we putting some energy, I think Lightbeam's prior experience as a niche provider and already having, so it uses a Tableau front end, and they've created some views of the data that are pretty rich. So I tend, from a quality background, to use that whole 80-20 thinking that, if we sort of take this bite size and focus on where a greater opportunity is. Lightbeam did a lot of the heavy lifting for us right away. They were already able, with a financial view, a quality view, looking at ways that any accountable care organization needs to understand its own data, to start to get us to focus on the right things to begin with. I will say that it's probably human nature, but I succumb to having blinders. Coming from a clinical background, my initial immediate jump was to go right to where I believe the action was. And that is patients with heart failure, patients with COPD, these patients who we all sort of subscribe to the belief are heavy users of our system. If we could just simply help them better self-manage, we could both bring our costs down, improve their quality of life, et cetera. And I'm not going to negate that. Those are all true statements, but I went to my comfort zone. What Lightbeam was able to show us is that there were some basic issues that we also, one basic issue that we needed to deal with, and that was attribution. Now, I guess somebody schooled in having run an ACO in the past probably would have had a leg up on me in that one. But the paradox with these new value-based programs are that with CMS, one of my objectives is to lower our total cost of care. Well, in spite of my interest in supporting lowering the total cost of care, if I don't get that patient in for at least an encounter during the prior year, I lose their attribution. So one of the pointers that Lightbeam gave to us that I wouldn't have naturally otherwise thought of is we've got to have an active program to make sure that patients are able to get in for their annual wellness visits, or that we have another mechanism to be sure that we're reaching out to them and getting them in to be seen and generating an encounter, or I lose them to our attributed lives. So that's an example of where there was sort of, I wouldn't say it's easy work because there's not much in this work that's easy, but it was one that would not have jumped out at me without their assist and without that initial help. Now, we're still actively working on those care management activities, and we've seen nice results initially, at least, but there's some basic blocking and tackling kind of work that the Lightbeam niche warehouse and some of its standard tools was able to point out to us. I was just going to add that another example of a challenge for us is as we're talking about the design of our primary care systems to be another key building block for us, another tool available to us and one that we've needed to work on was impanelment. How many patients do we have impaneled at each of our practices at what mix of risk? And we had some variations. So we have some providers who are probably trying to manage a panel on their own that it's probably extraordinary or nearly impossible for them to do so. So again, the data brings some opportunity to the table for us to say, is there a way for us to load level a little bit? Can we, rather than just waiting for a provider to become overbooked or to want to close their practice to new patients, what could we do to manage the number of patients impaneled to a provider?
Very interesting. I will say, if it makes you feel any better, we talked to a lot of ACOs, and this attribution issue is a pretty common complaint, if you will. You know, how can I manage these people if my attribution isn't quite right, or if I'm being attributed lives for whom I can't derive actions on. So I think your example is a really great one. Can you share some metrics or just really specific stories of things that have changed as a result of the data that you've been putting out there?
Sure, I'll share two. As we deployed these ambulatory care coordinators and we made a conscious decision to position them in the practices so that they were a part of the team and the primary care providers see them as an agent to help them. Just within the first month of deploying one, the primary care medical director for that clinic said that for a patient he'd cared for, had multiple hospitalizations previously. They'd never been able to successfully get the patient into the clinic post-hospital discharge for a transition visit to make sure med reconciliation was done and the patient was faring well and better understanding how they were going to manage after that hospitalization. They'd never been able to get the patient in, but by virtue of having the ambulatory care coordinator in the clinic, she reached out, understood the challenges and barriers to that patient, which were in primarily transportation problems. And the provider's marker of success was simply, this was the first time they'd been successful in getting this patient to come in and be seen in the clinic after a hospitalization to make sure that things were going as planned. On more of a quantitative side, I mentioned that we've been up and running for almost a year with these ambulatory care coordinators. We've taken a fairly simple pre-post kind of assessment of what were and there was no magic to our use of 7 months of experience. It was simply 7 months of it had elapsed since we had it implemented when we began to run the analysis. But we looked at the 7 months prior to placing these ACCs and then the 7 months post and really looked at utilization. So we identified patients who had been readmitted in the 7 months prior, were utilizing fairly heavily in the 7 months prior, had lots of ED visits. So within Lightbeam, we were able to develop registries or cohorts of patients that met a certain threshold of risk and or had more than 4 or more than 10, four hospitalizations, more than 10 emergency department visits, and they became managed cohorts. They became the focus of these ACCs. So we were then using Lightbeam and available hospital EMR data, able to also identify what were the 7 months afterwards like for them. And we showed a 45% reduction in total hospital-based utilization by that same cohort of patients. So we feel pretty successful. Now, of course, during that same 7-month period, new patients emerge as developing readmissions. But if we were controlling for who the target of the ACC's work was, we were able to demonstrate a pretty significant reduction in utilization. Now, we learned a little bit the hard way because we hadn't really preconceived that Lightbeam has the ability to take a snapshot or create a static cohort. And had we done that, we would have had to do a lot less manipulation of the data, because we would have been able to just track only those patients that were in their cohort at the very beginning all the way through. We had to weed out some patients that were accrued or added during that time frame for not having created that static cohort. And so we're in the process also learning some characteristics or benefits that the tools bring to the table that we probably learned the hard way would have been easier or better for us to use. But so we're using pretty high-level measures of utilization, for instance, but seeing some nice impact.
Well, if you can believe it, Mark, we have run out of time. I would love if you could, in one sentence, just give the person listening that's going to adopt their Pop Health tool a bit of advice.
I think you need to continue to make sure that end users of the information realize that there will always be work to be done to keep the data integrity where you want it. And it's going to require putting your shoulder to the grindstone and in a very detailed way, digging into the data to understand both how it works and how it can help you, but also what it's going to take to nurture and maintain that data in a useful way.
Thank you so much. Thank you to our audience, too, for tuning in. You can learn more about the show on the programs page on healthcarenowradio.com and lend your voice to the conversation on Twitter at #VoicesInDBC, and be sure to follow me on Twitter at BAHouck. I'm Beth Houck, bringing you the voices in value-based care you should hear. Until next time, have a great week.